Okay, so thanks for having me on the program. I'm Jen Kwok, and I'm an assistant professor at the University of Illinois at Chicago. So this paper studies the impact of primary care physicians on healthcare utilization. We care about healthcare spending because it's 18% of US GDP, and estimates suggest that 20 to 30% is wasteful. We also know that physicians may contribute to some of this excess healthcare spending. Healthcare providers generate supplier-induced demand, and physicians contribute to the wide regional and local variation in healthcare utilization. Among healthcare providers, primary care physicians, or PCPs, may be particularly influential due to their central role in the healthcare system. PCPs serve as patients' primary point of contact and coordinate care, and in some cases, PCPs even formally refer some patients to specialists. So for this reason, PCPs have become a common target of cost savings efforts. For example, managed care incentivizes PCPs to reduce spending, and health plans may induce patients to switch to lower cost PCPs through narrow provider networks. Now in this paper, I'll talk about a couple of things. First, in terms of long-run effects of patients switching to different PCPs, to what extent do differences in individual PCP practice styles, as measured by spending, explain utilization variation? The main empirical challenge here is that patients do not exogenously sort to PCPs, and there is indeed sorting. So for this reason, I use a two-way fixed effects model that includes a patient fixed effect and a PCP fixed effect to control for unobservable patient characteristics. This class of models has been used in a wide range of literatures, including in the labor literature, to separate the effects of employers and employees on wages. The main identification assumption in these two-way fixed effects models is that patients don't sort to PCPs based on time-varying patient trends. Using this model, I show that about 2% of the variation in utilization within regional geographic markets, it's due to differences across individual PCPs. I also then look at the short-run effects, and I ask, do patients incur switching costs in the form of temporarily higher utilization when they switch PCPs? The additional empirical challenge here is that patients may switch for endogenous short-run reasons. For this reason, I actually focus on patients who involuntarily switch PCPs because their PCPs relocate or retire. I then use an event study model with the same patient and PCP fixed effects to estimate the cost due to the switch. And I find about $500 to $700 in cost per patient switch. Now, taking these results together, I can think about what are the potential cost savings from changing PCP practice styles or moving patients across PCPs. And for example, moving a patient from the 75th percentile PCP to the 25th percentile PCP in the utilization distribution yields about $600 per year in savings. For data, I use fee-for-service original Medicare patients, and my outcomes will be utilizations as measured by patient payments. Now, let me tell you about how this paper relates to the literature. It adds to three main categories. First, my paper contributes to how healthcare providers influence utilization and other health outcomes. The majority of literature has focused on cases in which there's an emergency situation and patients are essentially randomly assigned to their healthcare providers. There are two papers that do focus on PCPs. The first paper from Kuleyev and co-authors studies the effects of individual PCPs on drug adherence in Denmark. Also, another paper, Fallon and Van Paris, use similar involuntary switches in Medicare and estimate the effects of patients switching to different types of PCPs. And they show that patient selection on unobservables is likely limited. This paper focuses on the effects of individual PCPs on healthcare utilization while directly controlling for unobservable patient characteristics. My paper also contributes to the literature on how factors that drive healthcare variation occur at different geographic levels. It relates the wide literature on across-region variation and also adds to the literature on within-region variation, which has looked at variation at the health service area level, variation across hospitals, and variation across hospital physicians. My paper focuses on variation across individual PCPs and studies their contribution to variation within regional geographic markets. My estimations focus on the within regional geographic markets context, because this allows me to think about how patients can be reallocated across PCPs within their regional market, or how physician practice styles can be changed within the context of the regional geographic market. Finally, my paper relates to the new literature on effects of patients switching to new PCPs. The health services research literature has one study that looks at PCPs who leave the Veterans Health Administration and effects there. And there's also a number of contemporaneous papers that look at retirements and relocations in Medicare and practice closures in Europe. My paper focuses on the effects of switching PCPs, both in the short run and in the long run. And specifically in the long run, I'm able to control for a PCP composition changes that may be correlated with PCP retirements, relocations, or departures from a healthcare system. Now let me tell you about the data I use. I use fee-for-service original Medicare data, and this used this 20% sample of beneficiaries from 1999 to 2012. In order to have a long panel, I focus on Parts A and B of Medicare and exclude Part D data. My level of analysis occurs using observations at the patient and quarterly calendar date level. I conduct my estimation within each of the 306 hospital referral regions in the US. I make some sample restrictions that are common. First, I focus on patients who are aged beneficiaries, ages 65 to 99 in the US. I also focus on Parts A and B, as I mentioned before. And so this original Medicare setting has a few main advantages. First, it covers most individuals who are over 65, who have relatively high healthcare spending, and also generally consider a PCP to be their usual source of care. Medicare, specifically original Medicare, is also fairly uniform across the US, which allows me to make comparisons across geographic markets and aggregate results to the US level. Furthermore, this context is relevant for Medicare cost-saving strategies, such as the Medicare Shared Savings Programs, ACOs, and Medicare Advantage. And those programs typically use PCPs to save on costs. Now, I'd also like to note that in this context, patients can choose PCPs and do not require referrals to specialists. Now, with this data in mind, let me tell you about some definitions I use. I define a PCP as a doctor of medicine or a doctor of osteopathic medicine in a specialty with family medicine, general internal medicine, general practice, or geriatrics. I assign main PCPs to patient quarters following the literature. Specifically, I assign patient quarters to PCPs with whom they have the greatest number of evaluation and management visits in the past year, specifically the current quarter and the past 3 quarters. I define a switch in PCP as simply a change in this main PCP assignment. I also make additional sample restrictions. The main sample restriction I'd like to cover here is just that I want to make sure that I'm studying patient quarters in which patients have a strong relationship with a single PCP. And for this reason, I restrict my patient quarters to those in which a patient has 75% of their PCP visits with their main PCP in the past year. For my outcomes, as I mentioned, I focus on utilization, and I define it as the sum of patient, Medicare, and primary payer payments. I can do this because there are no major differences in direct monetary incentives across PCPs. So utilization and spending captures a key dimension of physician practice styles. Furthermore, prices are administratively set rather than negotiated, so differences in spending reflect differences in utilization rather than differences in prices. In this presentation, I'll focus on all utilization and primary care utilization as my outcomes. And in the paper, I take a look at other categories of care, including specialty care, tests, imaging, hospital inpatient care, and emergency department care. So let me show you what the patterns look like around the time of a switch using these outcomes. So on this plot, the horizontal axis shows the time relative to a switch. I classify PCPs as origin PCPs if they're the PCPs that a patient switches away from, and I classify destination PCPs as PCPs the patient switches to. So in this case, 0 represents a patient's last quarter with their origin PCP. For clarity, I bin quarters into years, such that year 0 includes quarters -3 to quarter 0. And for year 1, I separate out the first quarter from the remaining quarters, 2 to 4, to more clearly show the patterns in the data. On the y-axis, I have log primary care utilization, which is simply adjusted for age, gender, and date. And on this plot, I'll restrict my sample to the balanced panel of patients who are consistently matched to their origin PCP for the 12 quarters before the switch and consistently matched to their destination PCP for the 12 quarters after the switch, to avoid having patients with multiple switches. So on this plot, what I want to show are patients who switch from, say, low to high spending PCPs or high to low spending PCPs. For this reason, I bin PCPs into quartiles based on the other patients they have. So for each switch, for instance, for a patient switching from an origin PCP to destination PCP, I take their origin PCP and bin them into quartiles based on other patients, essentially based on a leave-out mean, and I do the same for the destination PCP. So let me show you what this looks like. So this graph shows quartile to quartile switches between quartiles 1 and quartiles 1 and 4 in order to just focus on the largest changes. And I omit, for instance, the switches to and from quartiles 2 and 3. So let me focus on the area outside of the switch and tell you what it shows. So here, this plot shows that some patients have systematically higher or lower utilization. For example, if we focus on the blue line, we see that patients who are switching from high spending quartile 4 PCPs to other high spending quartile 4 PCPs have systematically higher utilization. The blue line quartile 4 to 4 switchers have higher utilization before the switch than the orange line quartile 4 to 1 switchers. And after the switch, the blue line quartile 4 to 4 switchers have higher utilization than the green line quartile 1 to 4 switchers, even though the patients are at the same types of PCPs. So now we see that patients do indeed sort to different types of PCPs. And so if patients explained all of the variation in utilization, we wouldn't expect patients to incur different levels of utilization when they switch to different types of PCPs. But here, we see that patients do indeed change their utilization, and PCPs do matter. So let me give you an example again. So we see here that the orange line quartile 4 to 1 switchers experience decreases on average, and the green line quartile 1 to 4 switchers experience increases in average. We see that these low to high and high to low quartile switches have relatively symmetric changes, in that the magnitude of the change is relatively similar relative to the overall trend. And finally, let me also point out that the utilization is stable before and after the switch, and the trends are roughly parallel. For this reason, we can think about utilization as being explained by a PCP component as well as a patient component. Now keep that in mind, and now I'll actually focus on the time during the switch. So we see here that the transition to the long-run steady-state utilization begins during a switch, during year 0. This occurs because the main PCP assignment is a 1-year retrospective view. We also see that the increase in utilization that occurs around the time of the switch is concentrated in the first quarter a patient is assigned to their destination PCP. This increase occurs for all types of quartile to quartile switches, which shows that one set of switch event indicators could potentially capture the increase in utilization across all quartile to quartile switching groups. Now, taking these patterns in the data, I can then construct an econometric model that reflects the patterns. I have a utilization measure YIT. I then include the same set of controls that I showed in the graphs. This would be patient age by gender controls, which represent predetermined demographic characteristics. And I also include quarterly date fixed effects to capture time varying market level factors. I then include a patient fixed effect and a PCP fixed effect. A patient fixed effect represents the level of utilization a patient would have at all PCPs. This reflects their time invariant health status or their time invariant preferences for healthcare. The PCP fixed effect represents the utilization a PCP would induce for all patients. This, for example, could represent a PCP's propensity to refer patients to specialists or the PCP's overall recommendation for visit frequency. So finally, I include a set of switch event indicators to capture the patterns around the time of the switch. And in order to be flexible and capture different types of switches, I include 4 sets of indicators. 1, I include switches between 2 PCPs in the same practice groups. 2, I include switches between 2 PCPs in different practice groups. And I also include switches from having no PCP to having a PCP, or from having a PCP to having no PCP. To place this model in a broader context, it's consistent with existing micro-founded models of supply and demand and draws upon the two-way fixed effect models from the labor literature. Now let me tell you about the assumptions that I need to hold for this patient to PCP switching process to essentially generate the parameters as I've identified them. So the first set of assumptions focuses on the exogenous switches. Specifically, I need to show that sorting in PCP switches is not systematically due to 3 types of potentially endogenous switches. First, I check that patients match to their PCP isn't systematically driven in this model and the patterns in the data. So for instance, an example that violates the assumption is if a patient who has arthritis systematically sorts to PCPs who recommend expensive treatments for arthritis patients, such as knee replacements, but don't recommend expensive treatments for other patients. And so when we look at the symmetry in the switches from high to low spending PCPs or low to high spending PCPs, it shows that this type of sorting is likely limited. Next, I check that patient-specific utilization trends aren't driving, patients aren't switching based on their utilization trends systematically to different PCPs. So an example that would violate this assumption is if a patient in declining health switches to PCPs who have greater appointment availability and allow them to make more appointments and generate higher utilization. Again, I take a look at the graph and I see that based on the parallel trends and the symmetry in the data, this type of switching is likely limited as well. And finally, I check that patients aren't systematically switching based on their transitory error fluctuations, at least in the long run. And so here, an example that would violate this assumption is if a patient in declining health systematically switches to PCPs who generate higher utilization. Here again, the parallel trends show that this type of switching is likely limited as well. And note that in this case, we can only see the parallel trends outside of the switching window. So for this reason, I omit the switching window from my practice styles analysis. And for my switching cost analysis, I focus on patients who involuntarily switch. I also make additional sample restrictions based on this model and based on requirements of the data and definitions. So first, the main point is that patients in PCP fixed effects are identified only within connected sets of patients and PCPs that are connected by patients who switch to different PCPs over time. Based on my main PCP definition, I also need to exclude the last 4 quarters of the patient's data because I need to see whether a patient in a given quarter subsequently completes a switch. And this, therefore, excludes end-of-life expenditures. Finally, as I mentioned before, I exclude the 5 quarters of the switch from the long-run practice styles analysis. So now let me show you quickly what the samples look like. I first start with 9.3 million patients and 210 patient quarter observations. Of these patient quarter observations, 94% are eligible for PCP assignment. And 72% of those eligible for PCP assignment are actually assigned to PCPs. I then focus on the subsample of patients who satisfy the 75% of visits requirement, and that's 94% of those assigned to PCPs. And that brings me to the second column. Now in the third and fourth columns, I further restrict the sample based on the sample restrictions I mentioned previously. There are fewer patients in patient quarters, of course, and then patients here are in the sample for a longer period of time, and they also have lower utilization, partially because I exclude these end-of-life expenditures. Now let me present the practice styles analysis. I use the Econometric model, and in this case, my parameters of interest are the variance of the PCP fixed effects. I conduct my estimation of this two-way fixed effect model within markets, omitting the patient quarters during the switch. I also partial out the effect of PCP switches and controls so that the utilization measure is purged of these effects. Finally, I use new methodology to avoid the limited mobility bias that occurs in the standard linear regression of these two-way fixed effect models in samples where there's limited switching between patients and PCPs. I also conduct a number of robustness checks. Now let me tell you about the results. So the main result in the practice styles analysis is that individual PCPs, fixed effects, and the variance of them explain 2.4% of the total variance in healthcare utilization. Now, when we look at primary care, we would expect the variance of PCP fixed effects to explain a greater share of the total variance there. And indeed, that's the case. So the variance of PCP fixed effects in using primary care as a utilization measure explains 12.6% of the total variance. And so what we take away is that PCPs explain a small but significant share of the total healthcare utilization. Now, let me tell you about the switching costs. We recall that there's a short-run utilization increase. I won't go into the mechanisms in the interest of time, but I'd like to point out that ex ante, it's not actually clear that there should be an increase. For example, if patients switch to new, less familiar PCPs, they may actually visit those PCPs less often and generate lower utilization. So in this case, we do observe a utilization increase. And so let me show you how I estimate the switching cost there. I return to the econometric model, and here my parameters of interest are the event time coefficients. I use patient and fixed effects and PCP fixed effects to sort of set the baseline for what utilization would be in the absence of a switch. And I assign baseline PCP fixed effects as the weighted average by quarter during the switch. And I do this because patients, on average, switch between the origin and destination PCPs and see some during the period during the switch. So with this in mind, I then focus on the switch event coefficients. And I estimate these over a balanced panel of patients. And I estimate separate sets of coefficients to capture different types of switches. Specifically, I use different sets of coefficients for involuntary versus voluntary switches, and for switches to PCPs in the same practice groups versus switches to PCPs in different practice groups. Again, I conduct this estimation within markets, and I use a linear regression with standard errors clustered by patient, PCP, and date. I also conduct a number of robustness checks. Now, let me focus on the involuntary PCP switches. So we need to exogenous switches because patients may switch PCPs for endogenous reasons. For example, they may switch PCPs because they want a second opinion after a new diagnosis, or they may suddenly have an acute condition that requires them to see PCPs urgently, and they may be willing to see any PCP in a practice group rather than their main PCP. And so these short-run types of endogenous reasons of switching would generate different patterns in the data than what I would like to capture. And so I focus on involuntary PCP switches where PCPs leave their states or Medicare. The identification assumption is that utilization deviations from the baseline are not due to factors unrelated to the switch. I define switching costs as the sum over coefficients estimated on the balanced panels of patients scaled to dollar spending. And so let me show you the results. Here, the first column indicates whether a switch is voluntary or involuntary. And the second column indicates whether a patient switches practice groups or doesn't switch practice groups. So here I find that for patients who switch PCPs and don't switch practice groups, they incur roughly $499 in excess utilization. Among patients who do switch practice groups, they incur roughly $726 in excess utilization. I can similarly do this exercise for primary care, and I find that primary care contributes to 20 to 30% of this temporary increase in utilization. Now, these are causal effects estimated based on exogenous switches. When we look at the bottom two rows, where we look at voluntary switches, we see that the switching cost that would be estimated among these groups is higher. So now let me turn to counterfactuals that I can construct based on the results from my long-run switching cost analysis and my short-run switching cost analysis. So when I look at counterfactuals, the objective is to calculate the differences in utilization between different parts of the PCP distribution. For this exercise, I consider a representative patient and a representative market. I further assume that patient fixed effects and PCP fixed effects have a bivariate normal distribution. Now, with this assumption, I can write the expected log utilization at a point in the PCP distribution. So this would be for PCPs with gamma J star fixed effect and for their patients who are observed to be there. So this expression is a sum of three components. The first is the expected patient fixed effect at gamma J star. The second term is simply the PCP fixed effect at gamma J star, which is gamma J star itself. And the third term is the sample mean utilization. So now I can similarly construct the counterfactual log utilization among patients at gamma J star who then go to see PCPs with gamma CF as a fixed effect. And so I can change 1 point in the PCP distribution, and I scale this to differences in dollar levels. So for example, this would allow me to say, what would be the dollar savings if I move the patient at the 75th percentile PCP to the median PCP? I can similarly take patients in a range of the PCP distribution and move them by integrating, say, from gamma L lower bound to gamma U upper bound. And so this would allow me to say, take the patients at the top decile of PCPs and move them to the median. Now let me show you the results, which represent sort of partial equilibrium of moving patients across different PCPs or changing PCP practice styles. So the first panel shows the change between two specific percentiles. So for instance, moving a patient from the 75th percentile PCP to the 25th percentile PCP would yield, as indicated in the first column, a savings of about $617 per year. In the second column, I also show what would be the number of years required to break even if a patient incurred the costs that are related to switching practice groups. We see here that that would be roughly a year. Now, if we move patients within a smaller range in the middle of the PCP distribution, that would yield substantially lower savings of $231 per year. I can similarly consider what would happen if we reallocated patients from the top deciles to the median. So this shows that if you were to reallocate patients from the top deciles to the median, you can generate high savings. However, this might be difficult in practice. And so if patients who were reallocated from top deciles still sorted to other high spending PCPs, the savings are substantially lower. And we really want to consider sort of the number of years they stay with the PCP to see if the savings would sort of break even if patients are required to switch PCP practice groups. Now let me tell you about some of the policy implications. First, I'd like to point out that altering PCP practice styles is tricky. So health insurers incentivize PCPs to coordinate care or spend more wisely. But because, say, moving a patient PCP's practice style from the 60th percentile to the 40th percentile generates modest savings, we would also need to take into costs of incentivizing PCPs and running these programs. Second, reallocating patients across PCPs requires us to consider the short-run switching costs. So health insurers who manage PCP plan networks may choose to exclude high-spending PCPs from their networks who were previously in network, and that would cause all of their patients to have to switch to other PCPs. Similarly, patients trade off PCP network and breadth. So if a patient decides to switch to a narrow network in order to sort of save on premiums, they also need to consider that if they need to switch PCPs, they may incur higher utilization. Finally, the high switching costs points to policies that points to the need for policies to reduce switching costs. So increasing transparency could reduce involuntary PCP switches, and we may also want to have policies to mitigate switching costs, such as facilitating medical records transfers. So the main takeaway of this paper is that PCPs do matter, both in the long run and in the short run. I estimate the long run and short run effects of switching to different PCPs using over a decade of Medicare claims data and using a model with two-way fixed effects and events to capture unobservable patient characteristics and the patterns around the time of the switch. I find that differences in individual PCP practice styles explain 2% of the within market variation in all utilization, and patients incur one-time switching costs of $500 to $700. I find that potential long-run cost savings of reallocating patients across PCPs are similar in magnitude to one-time short-run switching costs. For this reason, policies would need to consider both when trying to change PCP practice styles or reallocating patients across PCPs. So thank you very much.
Thanks, Jen. That was a great presentation. There's very little that you haven't thought about, and that's clear from your presentation, and it's very clear from the paper. If it's not in the paper, it's in the footnotes, and if it's not in the footnotes, it's in an appendix. So 90% of what I'm about to say is stuff I think that you're probably quite aware of, but I want to maybe highlight some points that weren't as obvious from your presentation, and maybe were points that were put largely in the footnotes in the appendices. I also appreciate this topic. I've had family members who, under Medicare, engaged in voluntary PCP switches. And in fact, in a managed care context, myself in a non-Medicare setting, was subject to an involuntary switch a couple of years ago. So I do appreciate, I think, the context from which you are writing this paper and its importance. So I want to cover about 5 points, and let me just get right to it. So the first one, I think, is obvious, but I think maybe so obvious that it needs a little bit more attention, which is the paper's fundamentally about switching, and switching fundamentally relies on the assignment of PCPs in order to define what a switch is. And I guess I would urge you maybe to do what you say you are doing in ongoing work, which is to assess how this 75% threshold that you use for making an assignment, that is 75%, at least 75% of visits in the previous 4 quarters has to be with one provider in order to satisfy your threshold. To think about that and its implications, because I think those implications could be large. And I think it may be the case, and I don't know this, but that they could be particularly large for low utilizers. For example, if somebody has 1 visit in the previous 4 quarters, does their 1 out of 1 visit satisfy the threshold versus somebody that has 3 visits in the previous 4 quarters, 2 of which are with the same provider, which, again, mechanically I read as not satisfying the threshold. And I think that when you've got these low utilizers with 1 or 2 or 3 visits, these issues become even more salient. I also wonder, and I think this is in a future version of your research, whether the focus might be able to be shifted from PCPs specifically, individual providers, to PCP care teams, where care is now so often in primary care settings being delivered by teams that include MDs, nurse practitioners, PAs, and others. Is the relevant switch anymore a single individual provider to a different single individual provider, or is it from a single care team to a different care team? I'm not sure the measurement of that is feasible, but at least put it on the radar screen as a conceptual issue. A second and related issue is who is a PCP? And again, I believe you're well aware of these issues, but I would just raise this again because that definition may affect different parts of the population differently. The leading example we might often turn to is an OBGYN as a PCP for women. In many cases, I know of such a case, a cardiologist became a de facto PCP for a patient that was having a spectrum of severe health problems, not only managing cardiology care, but effectively managing all aspects of care. I just wonder if there is some potential sensitivity to the definitions of who are PCPs. For example, do OBGYNs and cardiologists bill for the E&M services that are of particular interest to you? I don't know, but I wonder if that might be worth looking at. My third point has to do with the issue of scheduling appointments. And you mentioned this and touch on it in a couple places in the paper. But I might urge you to pursue this further along the following lines. It could be the case that for some patients, and I guess I'm imagining maybe unhealthy patients, that challenges in getting appointments or reputed challenges in getting appointments may preclude the optimal switch that a patient might like to make. I might want to switch to provider X because I've heard good things about that provider, but I also have realized upon asking or calling the office that I won't be able to get an appointment with provider X for many months, and so I'm going to switch to provider Y. If that's the case, the optimal switch isn't revealed in the data, and in some sense, then the data don't reveal the entirety of patient preferences that might be involved with the switching process. So there is, I'm guessing, this is not a field I know well, I'm guessing there's some literature on scheduling difficulties in the Medicare context, and you might want to pursue that a little bit more in depth. The fourth point I'll make has to do with what I'm calling life cycle utilization. And let me just touch on a couple dimensions of that. One is that I think in a very simple context, it might be interesting to stratify your empirical analysis by age categories, just very simply. You've got age in as a control variable, but I wonder if you might find interesting differences if you just look at 2 or 3 different age categories. Another angle here is, and you touch on this, is end-of-life care, where in the current version, you omit the last 4 quarters for a patient once you know that there's a time of death. And you indicate that you have ongoing robustness work involved here. I do wonder, though, about the treatment of end-of-life care. I mean, in an extreme case, if the concern is cost impacts, it's simply the case that patients don't incur cost after they die. And I know that sounds a little bit glib, but that may provide a different frame on how you think about some of these end-of-life issues. And there's also just a general issue concerning mortality selection, which is, standard in an analysis like this. But I think it forces emphasis on considerations that what your data reveal, an observation in your sample, is a patient quarter, not a patient. And I think that, that raises some potential questions about the link of what you're doing to policy. Is the policy question having to do with patient quarters, or is the policy question having to do with patients? And I don't know the answer to that, but I think it might behoove you to pursue that a little bit. The last set of points I'll make is on market definition. And again, you've handled this, I think, really nicely in the paper. You've emphasized in a number of contexts that you are focusing on within market phenomena. You've got these 306 hospital referral regions set up more or less like islands that don't have much interplay with each other. And that's where I'd like you to maybe consider a couple variations on what you do. One is on how well primary care utilization patterns adhere to HRR definitions. And I'm willing to think that they probably adhere pretty well. The second one that I might ask you to consider is whether the within market utilization and the quartiles of within market utilization that you use to define the provider categories, is within market utilization the right policy question to be focused on? What Skinner et al. Call a cowboy doctor in one market might be a comforter doctor in the adjacent market. And so I'm just wondering if you might, even though your analysis could still continue to be conducted, your econometric analysis could still continue to be conducted at the HRR level, whether the reference quartiles might be interestingly defined outside of the market. It's using all the adjacent HRRs, using the state, some other maybe more policy relevant definition of what these utilization quartiles look like. And the last thing I'll point out, and this is a technical issue, and I'll put this under miscellaneous, and you touched on this a little bit at the end of your talk, but the paper goes into great detail about how it's challenging to try to estimate these PCP fixed effect variances. And I think you do a really nice job explaining that, but you also note in the paper that the method you use sometimes results in negative variance estimates. And, variances have these nice decomposition properties that you explicitly point out in the paper. But when you've got negative point estimates of some of the variances, then those decomposition properties probably don't hold. So what I wonder is whether there may be alternative measures of spread of these PCP fixed effects that you might be able to tease out of your data that don't rely on the specifics of various decompositions. I don't know if there are such approaches, but you might ask some people that deal with these issues what their instinct would be. Are there interquartile range type measures that you could appeal to, for example? I don't know, but I think it would be worth pursuing that. Anyway, thanks for giving me the opportunity to read and discuss the paper, and I look forward to hearing further reactions.